forward towards your topic. It's about schizophrenia and other psychotic disorders. Okay. Uh, you have few questions, right? It's about the first question about disorganized behavior. So disorganized behavior, you know, that is an important symptom. That is one of the psychotic symptoms. So it is inconsistent behavior or that change in behavior that is bizarre in nature. For example, can I ask you a question so that can you give me example of disorganized behavior?
Like wandering around.
Okay, good. So aimlessly, wandering around aimlessly. Childish behavior, uh, like um, walking footed, meaning that without wearing any slippers or any shoes, okay, or sometimes stripping on oneself on the public, or walking naked, eating garbage, smearing feces on the wall. All these are called, or childish behavior. All these are called disorganized behavior, which is deviant from the normal behavior. Okay, and it is inconsistent with the normal form of behavior. That's why it's called also bizarre behavior. So it is important, and of course, it should be noted. You know, it's usually this behavior is observed by the family members, by the friends, or someone who knows the patient that you inquire during taking collateral history. Okay, but sometimes the patient have been told by the family members you were like doing that and walking naked or wandering around aimlessly, so the patient can tell you this information, or mumbling to himself or talking to himself. All these are types of disorganized behavior. Okay, but also it can be observed during mental state examination when you are observing the patient's behavior. Okay, and let's say in the ward, while the patient in the ward, it can be also observed. So it, you mean it's observed and or informed by the others, like the family members. Okay. The second question is how to differentiate between depersonalization and delusion, right? So, so there are many differentiating points. For example, is delusion is a type of thought disorder, while depersonalization is dissociative symptoms or perceptual disturbances. Okay, so what is a delusion? So we go to the basic to remind ourselves about what is a delusion in order to understand the differentiation. Anybody can answer?
Fixed false belief. Fixed false beliefs that is unshakable, built on inadequate ground, runs contrary to the cultural, socio-cultural background of the patient.
Okay, so that's good, meaning that it is real for the patient, right? It is, and the patient is, they have disturbance in the reality testing. This is the differentiation. So in depersonalization, it is result in, let's say, its experience of feeling detached, as if the patient are observing themselves from outside. The patient may feel that, for example, being in a dream-like experiences, but their reality testing is not impaired. This is the point of differentiation. Okay, so the reality test is still intact, which is a differentiation from the delusion, in which it is impaired. Okay, is that clear?
Yes, Dada.
Okay. So it is not a form of psychosis, as the person able to distinguish between their own internal experiences and the objective reality of the outside world. The other thing is how to differentiate between what's a grandiosity, overvalued idea, and delusion of a grandeur. Okay, this is a question. Now we know what is a delusion in general, right? So a delusion is a fixed false belief inconsistent with the patient's social, cultural, educational, religious background. It cannot be corrected by reasoning, meaning that when you cannot challenge the patient towards the truthness of the belief because the belief is held with very strongly and cannot be changed. So overvalued idea is defined as acceptable, comprehensible idea pursued by the patient beyond its normal reason, bounds of reason. So it can be it can be reasonable and understandable in themselves according to the culture, but it can unreasonable dominating the patient's life. For example, I give you an example. Concern or overvalued about calories. You know, in anorexia nervosa, the patient is having overvalued about the calories. Culturally, it's acceptable to think about the calories, but what makes it abnormal when the patient is holding this belief beyond the normal level. It seems to be acceptable, but the patient excessively take it beyond the normal level. So the overvalued idea can be differentiated from depression from the delusion, sorry, in the form of that the theme tend to be culturally common and acceptable in overvalued idea. Okay, and of course, you know that the patient is able to acknowledge the possibility that the belief may be or may be not true. While in delusion, you cannot argue about that because it's a fixed false belief. So overvalued idea is this is the difference from the delusion. Is that clear?
Yes, doctor.
Okay. Moving forward to answer also one question about grandicity and inflated self-esteem, right? So grandiosity is a spectrum ranging from a sense of superiority in which the one consider himself or herself as a unique person, better than others, and the idea are original, and opinion should be implemented and outstanding, but it can reach to the extent of delusional intensity. Then, when it reaches the delusional intensity, meaning that the definition of delusion can be implemented, then it will be as a false, unshakable belief, then it becomes a delusion of grandeur. So it's a spectrum. While in inflated self-esteem, it is not a delusion. It's just a belief that he is better than others. But it is, he feels that a belief like this, but it's not reaching to the delusional intensity. For example, an example of delusional intensity, the patient like believe that he just the patient just has just finished primary school as educational level, but he believes that he can invent a drug to treat cancer. And it is all the criteria of a delusion is there. It's fixed, false, unshakable belief. While an example of inflated self-esteem, someone can say, I'm the best writer, I'm the best student, I'm the best teacher, or something like this. But it is not to the degree of a delusion. Okay? What else? Prodromal and depression. Okay, what are the features of prodromal phase of schizophrenia?
Asociality, alogia, anhedonia, avolition.
Not the negative symptoms, the prodromal phase. You are asking about prodromal phase, right?
Social withdrawal.
Okay, good.
Change of behavior, doctor.
Okay. So it is a gradual onset of symptoms. What happened in these symptoms? We have some negative symptoms, yes. It's resembled to the negative symptoms of schizophrenia, yes. Okay, what else we have? Patient become yeah, less social, absence from work, okay, decline in the functioning, okay, and maybe the patient become more superstitious, but and we can have anhedonia, loss of interest, okay, avoidance of social interaction, avoidance of work, being irritable, sometimes having odd behavior, but there is no delusions nor hallucinations, okay, during the prodromal phase. But we have some features of negative symptoms like sometimes anhedonia, loss of interest. But how we can differentiate it from depression? Again, we have to apply DSM-5. The key to answer this question always to apply DSM-5 criteria. There must be depressed mood and the other features of depression, like guilt, suicidal ideation, worthlessness, weight changes, sleep disturbances, so other features of depression. Okay, so this is the way of differentiation between the prodromal phase or the negative symptoms of schizophrenia on the other hand and the depression. Okay,
Doctor, is it
yes.
possible to have both at the same time? Like the patient is experiencing depression, but the prodromal phase at the same time?
Okay, you can have schizophrenia. Depression and schizophrenia can be like sometimes during the illness, can be due to present during residual phase, for example, can be happened in schizophrenia, or can after the positive symptoms of schizophrenia, meaning that after the acute phase, when the patient become to the residual phase, then they can have what we call post psychotic post psychotic depressive disorder of schizophrenia. Okay, so it can be the most important that to apply DSM-5 criteria in which we have the depressed mood must be there. Okay, and other features as well. Okay, but the onset we cannot only diagnose schizophrenia in the presence of prodromal phase, right? There must be criterion A for at least 1 month, right?
Yes.
Yeah. Okay. What other question? You have the Grandiose and Inflated Self-Esteem, I think already touched this issue. Then we have what you have the somatic passivity and delusion of control. Delusion of control in which the patient, what's believed in delusion of control? What we have in delusion of control?
Met act, met impulse, and met feelings.
So the patient will believe that there is
external
their actions and feelings are controlled by external forces or external agencies that controlling his body. So actually, some books saying that delusion of control and passivity experiences are the same because they are caused impulses, made feelings, made actions, and we have also somatic passivity. So somatic passivity is a part of the somatic of the passivity experience in delusion control, in which the patient is passive recipient that to the body sensation can be manipulated by external forces, meaning that the patient can believe that his internal organs can be manipulated uh, by external forces. Like, for example, the patient may feel that his stomach is churning. Okay? What are the important premorbid history? What are the important premorbid history, personal, family, and schizophrenia and psychosis need
Doctor,
to be asked?
may I
Yes.
ask about just now you mentioned that the somatic passivity is the subset of the delusion of control, meaning that what are the other subsets under the delusion of control, Doctor?
Okay, as I told you, passivity experience and delusion of control, all in some books are the same, experience. Under these passivity phenomena, and under these, there will be many subtypes, like made impulses, made feelings, made actions, and somatic passivity. But overall, the definition is the same, right? Being controlled by external forces or external agencies that controlling certain part, other feelings or impulses, or but somatic passivity is a part, but it has a specific meaning because it's one of the, of course, it is one of the Schneider symptoms in which the patient believes that his internal organs are manipulated by external forces. Okay. Premorbid history is important in not only in schizophrenia, in any mental illness, because it can be one of the etiological factors that predispose to that particular mental illness. For example, schizophrenia, schizotypal, and schizoid personality can predispose towards schizophrenia, and some other types of personality disorders can predispose to other mental disorders. Okay, but also it affects the prognosis, and of course you need to affect the management plan. That's why it's important, and all the aspects you have to assess the social interaction, you need to assess the predominant mood, you need to assess the character of the patients and the coping mechanisms and moral and beliefs. All these are important part in the assessment of premorbid personality. Okay, if a patient has fulfilled a delusional symptom such as delusion or psychiatry, should we proceed to ask whether, of course, patient can be presented with many types of delusions. So you have to allocate all these. You have to ask about all the types of delusions. And the same goes for the hallucinations. Sometimes the patient having third person auditory hallucinations, sometimes second person auditory hallucination. Okay. So we have to allocate all these types. Even if you have enough symptoms, even if you have enough two symptoms, you have to look for the other features of schizophrenia, disorganized behavior, catatonia, negative symptoms. All these you have to look for it. Okay.
Doctor, may I ask? Just now you mentioned that once we already establish one type of delusion, then we need to explore the others. Aside
Yes.
from the diagnostic value of doing so, is there any importance in terms of management, doctor?
Yes. Yes. How do you, because how you say that the patient is improved when all the delusion subsided? If the patient, one delusion is already resolved, the other still, so it's partial recovery, right? That's why we need to make sure that all the beliefs, the delusions or whatever perceptual disturbances, are resolved. That's why we need to know. Okay? And also, sometimes the patient is very important because the patient is acting on their beliefs. If you just mentioned about delusion of reference and you forgot about persecutory delusion, and patient may act on that. So it's very important. Okay. Yes, you have to look for the features of, that, schizophrenia etiology, there is no specific, what to say, that etiological factors, but there are many factors we attribute to the etiology. But usually these factors is started from the, we have the biological factors, the psychosocial factors, we have the, other factors, environmental factors. So biological factors can be genetic factors. So all these you have to take in consideration. Can the patient positive symptoms or not? Can the patient present with both? Yes, of course, can present with both. But usually negative symptoms, usually in chronic schizophrenia, more prominent. And, that with successive episodes of schizophrenia, more to have negative symptoms than positive symptoms. And in chronic schizophrenia, or what we have, the positive symptoms may present, but would have in attenuated form. This is usually during residual phase. But still can patient have positive and negative symptoms. Some books saying that hypnagogic and hypnobambic as a type of pseudo hallucination. Some books saying that it's a type of hallucinations. Okay, but all the books saying that it's not diagnostically, it's not very significant because it can be habit in normal people. How to differentiate substance-induced psychosis and schizophrenia? This is a very important question, but it has a straightforward answer if you read the topic. Again, the key answer is to apply the Dsm-5 criteria for both diagnoses. Okay, so in schizophrenia, we know the diagnostic criteria, right? It's well known. And we're supposed to know that also substance-induced psychosis, we have either or hallucination or delusion or both. So, and the substance is capable to cause that symptom. So what make that it is the factors that more towards substance-induced psychosis? Can you tell me?
Is more on temporal effect and dose dependent in substance induced.
Meaning that you should look for temporal association between taking the substance and having the psychotic features. So whenever the patient taking the substance, he will or she will develop psychotic features, of course, during intoxication or withdrawal. Okay? Then also the psychotic features in substance-induced psychosis is shortly lived, meaning that it will subside after a while after stopping that particular substance, while in schizophrenia it will last. Okay? And of course, we have the course of schizophrenia. But the course of schizophrenia is chronic with multiple exacerbations and remissions. And in between, the patient cannot return to the baseline functioning with the successive episodes. Also, we have to look for the other features of schizophrenia, like formal thought disorders, negative symptoms, catatonic features. All these are features supportive of schizophrenia. And then, of course, family history of schizophrenia. On the other hand, let's say if the psychotic features developed prior to the onset, or prior to the take of the substance, so it is not related, right? And also if the psychotic features persisted for a substantial period of time despite the substance has been stopped and even the effect have been stopped for example, more than 2 months, 3 months, then it will be not substance induced. Meaning that, for example, if the patient last time still having psychotic features for the currently for the last 6 months, despite the last drug intake of amphetamine, for example, it was 6 months ago, the last intake, but the patient still having these psychotic features. So it is not a point for substance-induced psychosis. It's more towards another diagnosis, which is schizophrenia, because the duration more than 6 months. Okay? So again, the detailed history is very important. Look for the temporal association between the drug and the psychotic features. Look for the family history. Look for the other symptoms. Okay? Ask if there is any period that the patient was abstinent from the drug for more than 1 month. And during that period, was there any psychotic features or not? Okay, so these are important questions for differentiation. In addition to the other features, of course, of intoxications and withdrawal with support. Okay, the diagnosis. Yes.
I have a question. How can we know that, for example, the patient has abstinence from the drug itself? How are we going to differentiate either its temporal effect or because he is improving because of our treatment?
Of course, temporal association means that whenever the patient is taking the drug, there is psychotic features. Stopping, no, not taking the drug, no psychotic features, because these psychotic features are shortly lived if it's due to drugs. Okay, and then you ask during abstinence. For example, patient was in DIC, Drug Intervention Center, for the last 3 months, and during that period, the patient didn't have any psychotic features. Okay, or on the other hand, the patient was developed psychotic features, so it is not during these 3 months, despite not taking the drug. So it is not a drug-related psychotic feature. It is more towards another mental disorder. Understand?
Okay, doctor.
Okay. Do we give antipsychotic in a drug-induced psychosis? Yes, you can. If the psychotic features are severe and causing severe disturbances in the patient, I can, for example, agitated and aggressive behavior, and the psychotic features are very severe, so we can use for short term. Important drug psychotherapy need to remember. I cannot understand what's that question. It's vague. All the drugs are important. You choose the drug that can suit the patient well. It depends on the diagnosis. Okay. Now, how we can differentiate between schizoaffective and MDD and psychotic MDD with psychotic features? Okay. Okay. The same thing is to apply the Dsm-5 criteria for each diagnosis. In schizoaffective, we must have the psychotic features for at least 2 weeks without most symptoms. This is the point. Okay? In MDD with psychotic features, the psychotic feature, and schizoaffective, the psychotic features can be not mood incongruent. Okay? And we have the criterion A of schizophrenia concurrently with the mood episode. Okay? And of course, you differentiated from the MDD with psychosis, with psychotic features, in which mostly the psychotic features are mood congruent, meaning that the delusion can be, what type of delusion? Example, nihilistic delusion, delusion of guilt, okay, delusion of poverty, and the hallucinations can be in the sound of mood congruent, like patient hearing voices telling him that he is useless, he is a failure, or ask him to end his life. Okay, all these are mood congruent during MDD. And usually improvement of the mood in MDD can lead to improvement of the psychotic features. Okay, so these are the points of the, and of course you look for the, that family history of depression and other features of depression. So the key points is to differentiate, is to apply the DSM-5 criteria. You should have at least 2 weeks of psychotic features without most symptoms. And of course, the psychotic features can fulfill the criterion A of schizophrenia together with the mood episode. And the other question also, we have to apply the Dsm-5 criteria, because even if successful treated for the less than 1 month for criterion A, but the overall duration should be at least 6 months, including prodromal phase or residual phase. So overall, you should look for the Dsm-5 criteria for any diagnosis. Okay? So any other questions? So
Assalamualaikum, Doctor.
Alaikum assalam wa rahmatullahi ta'ala wa barakatuh.
Doctor, I'm Uzair. I would like to ask regarding the CPG of schizophrenia. There is a role of cognitive behavioral therapy and also cognitive remediation therapy.
Mhm.
So in which patient that we actually felt that it is suitable for undergoing CBT and CRT, doctor?
Okay, good question. Of course, those would have at least partial insight, because the core of cognitive behavioral therapy is to change the negative thoughts and beliefs, right? And dealing with these psychotic features. So if the patient doesn't have insight towards the illness, it will be difficult to start CBT, because the patient cannot change these beliefs. So unless your patient have partial insight towards the illness, then it will be beneficial. Otherwise, it will affect the therapeutic relationship with a patient when you try to contradict or try to, rationalize, or try to, about the delusional belief. You want to ask the patient about these beliefs are not true, so you cannot challenge these beliefs. It will be difficult if the patient having a poor insight. Okay.
Yes, doctor. Okay.
So schizophrenia and the other psychotic disorders is very important topic. Okay, so I need you to read it carefully, and then I need you also to remember not only the the features or the etiology. Not only you have to read it all, but you have to remember also the DSM-5 criteria for each diagnosis. It's very important, because you cannot diagnose without knowing the DSM-5 criteria. Okay, and this is also help you to differentiate between the different illnesses, because they may share the same symptoms, but there are points of differentiation in terms of DSM-5 criteria, like we discussed about differentiation between substance-induced psychosis and schizophrenia, or even schizoaffective and schizophrenia. For example, schizophrenia and schizoaffective, how we can differentiate, or also schizophrenia and MDD with psychosis. Can I ask you this question? It's similar to what I said earlier about schizoaffective and MDD with psychosis. Now we add schizophrenia as well to the spectrum. So how we can differentiate? Anybody want to take this question?
Just like you said, Doctor, we have to use the DSM-5 criteria for each and all the diagnoses. So for schizoaffective disorder, if my memory serves me well, in the past 2 months, the mood starts, and the mood symptom starts for 2 weeks and then stops, and then the psychotic symptoms begin. Muhana, would you like to continue? Because I don't remember much anymore.
Okay, you mentioned the earlier part is good by applying this DSM-5 criteria. Okay, the issue in schizoaffective, what we have, the issue here in schizophrenia, we can have mood symptoms, right? We can. The patient will become depressed because of the voices, right? Or because sometimes happy because of the voices, because sometimes the voices have grandiosity or grandiose delusion, so we become happy. But most of the time they are distressed and feeling dysphoric because of these voices. But these mood symptoms are not persistent in schizophrenia. The mood symptoms not persistent. Okay, while in schizoaffective, what we have? We have prominent and concurrently depressive episodes. It's not symptoms, episode. Okay, and concurrently with criterion A of schizophrenia. Okay, and of course there is one criteria saying that what is the majority of the time? Mood symptoms in schizoaffective, meaning that majority, meaning that more than 50%, right? It will be so that's why you have to explore the duration. So you have to take chronological history about the symptoms, how it started. Okay, so careful history. Then you see estimate the duration. So in DSM-5, mentioning that for schizoaffective, the majority of the symptoms spent in the mood episodes. Okay, and then concurrently we have depressive symptoms. So not only depressive, mood symptoms, whether it is in depressive type or in the bipolar type, together concurrently with the criterion A of schizophrenia. Again, we look for the other features of the history. In schizophrenia, the course is chronic with multiple exacerbations and remissions. And if we have mood symptoms, it will be not persistent like in schizoaffective. Okay, so at the end, how we differentiate? We differentiate by using the Dsm-5 criteria. That's why I'm saying, please remember the Dsm-5 criteria for each disorder. Okay?
Doctor, I have, I'm sorry, I'm Hannah. I have two additional questions. The first one is regarding ECT. One of the indication for ECT is you have the catatonia, and but the other one that we read is about prominent affective symptoms. How do we objectively define the prominent affective symptoms?
Yeah, when the patient presented, sometimes the patient presented with, depressive episode, or high suicidal ideation, or high suicidal risk because of the, sometimes, as I told you, post-psychotic depressive disorder of schizophrenia with high suicidal risk, it can be indicated for schizophrenia, for ECT. But catatonia is one of the major indication of ECT, one of the main causes of the indication of ECT in schizophrenia.
Oh, understand. The second question is for post-psychotic depressive episode. If this episode meet the criteria for MDD, do we treat them with macam like MDD? So there be multiple drugs taken by the patient?
Sorry, come again. If we have MDD,
Yes, post-depressive episode. At first, it's just an episode, but then subsequently it can evolve and meet the criteria for MDD, which 5 out of 9 symptoms, at least 2 weeks. So, do we also give pharmacotherapy to these schizophrenia patients, or we will just diagnose it as post-psychotic depressive episode and just treat it for a shorter period of time?
you may add antidepressant, depends on the severity. You may add if the patient can fall, but you should differentiate it from the negative symptoms. Understand? Because there must be a depressed mood and the other features, okay, of depression. Because in chronic schizophrenia or residual phase, we have mainly negative symptoms. One of the negative symptoms is anhedonia. So you have to be careful in the diagnosis that it is depression, and then you may add antidepressant for a while until the depressive, that as a treated as a depressive episode with post psychotic depressive disorder of schizophrenia, or post
Yeah.
psychotic depression, post schizophrenic depression.
I understand. Just want to confirm. So it means that this depressive episode of post-psychotic, in the residual phase, this episode doesn't really affect by improvement of the psychosis, right?
No, you mean that it is, the patient will develop this, maybe the etiology is not clear, but it can be after the patient having some insight towards the illness, realize the impact of the illness on his or her life, then they become depressed. That's why you need to deal with all these factors. And of course, the treatment of schizophrenia will help much more to improve, not to develop depression, because that it's not only giving medications, it's by biopsychosocial spiritual. You also, by patient become much more improvement of the function, become independent. All these will improve the self-esteem of the patient. All these factors. Okay.
Okay. Thank you.
Welcome. Okay, so Any other thing? I know it is a very big topic, okay? But I hope that you already read it and digested, okay? And it's nice to have all these questions, means that you are, you already read the topic very well, okay? And you have these questions to ask, okay? If you don't have any question, I would like to thank you for organizing this session. Hopefully you already got some benefit from me. And I wish you all the best in your exam, inshallah, and in the future. Okay. If you don't have any further question, I will end this session. No further question?
Inshallah, doctor. Thank you very much
Okay.
for
All the best. Can we end this session with citations?
Yes, okay.
Okay. Thank you. Thank you. Assalamu alaikum.
Thank you so much.
Thank you. Thank you very much. Assalamu alaikum.
See you again.
See you.